Grant Hogue from Boston Children's Hospital, and this is the Scoliosis Dialogues. This is the official podcast of the Scoliosis Research Society. I'm honored today to be joined by someone who I would consider to be a mentor as well as a visionary in the care of children with early onset scoliosis. That's Dr. Behrooz Akbarnia from San Diego. We are also joined by his co-authors from a recent publication that's in Spine Deformity, the official journal of SRS. And I'm going to allow Dr. Akbarnia to present his co-authors. The title of their manuscript is Proximal Foundation, Anchor Variation, and their Correlation with Unplanned Return to the OR in Children with EOS Treated with Magnetically Controlled Growing Rods. So, Dr. Akbarnia, please introduce your co-authors for us.
Well, thank you, Grant, for the opportunity to discuss this article. Fernando Rios is one of our former fellows and now practicing in Mexico. It was his main project and was able to present it both in IMAS as well as was presented in SRS. And Bahar Shahidi, she is the associate professor of Department of Orthopedic Surgery at University of California, San Diego. She is the scientist behind this project. There are other co-authors that from pediatric spine study group, and they all have contributed significantly to this paper.
Thank you so much, all three of you, for coming. Welcome, Bahar, and welcome, Fernando. And so how did the three of you kind of come together with this project? Really, what was the genesis? Who had the question and where did you come from?
Well, I think I can answer that by just saying a little bit of a history of anchors in growth-friendly procedures. Initially, I don't want to get any credit, but the dual rod in the treatment of growth-friendly distraction type techniques really came from first Mark Asher and Richard McCarthy. And so we were able to get some implants early 90s and to fit the small skeleton of small children and put the data together, and then the study group sort of started. First, I think the initial things was hooks. You know, at that time, screws were not very popular in the thoracic spine, and the hooks were at the top, and just getting the idea from Mark Asher was the level of T2 was the best. I have no data to support that, but that's where we started with the screws, with the hooks at the proximal foundation. And then as the screws become more popular, we had distal screws and proximal hooks. And then we look at the comparing biomechanically, we found that the hooks with the cross connector, 4 hooks, supralaminar hooks with the cross connector was equal to 4 screws. So gradually the screws came about, and after a while, the MCGR was introduced, and we wanted to see what are the best best anchor configuration that would lead to least complications due to implant-related complications. So we felt that the PDSSG database is a great way to get the data that we wanted, and that's how we were able to start this project.
Fantastic. And so either Bahar or Fernando, would you mind giving us kind of a 2 to 3 minute summary of your methods as well as your findings for this project?
Sure, I think I can kind of give you a brief summary. Basically, what we did was we used the Pediatric Spine Study Group database, which was, as you know, a prospectively collected international database. We did a retrospective analysis of about 400 patients. And these were all patients that had a diagnosis of EOS that were treated with dual MCGRs, and we kind of included their data if it was their primary surgery. And so, classic inclusion criteria, they had to be less than 10 years old. They had to have a complete X-ray data set. We had a minimum criteria of a 2-year follow-up. And so we basically then looked at, I say we, but mainly this is Fernando and Behrooz and the other surgeons on the team, looked at over 1,500 X-rays and documented each construct configuration, things like what the UIV was, how many levels the proximal construct configuration spanned, what the number and exact anatomical location of each anchor was, and all of the demographic, etiologic, and other information that we had available to us with the PSSG data set. And what we ended up with at the end was a map of construct variation across a multitude of surgeons and patients. And from that, we verified by looking at the X-rays from their, prior to their primary surgery and when we saw the construct had changed, whether somebody, along with the information from PSSG, whether somebody had an unplanned return to the OR. And our main results were that the configuration of the construct, not unsurprisingly, did impact the incidence of the unplanned return to the OR, and in particular, the choice of the UIV, as well as the amount of kyphosis correction in the surgery were predictors. And so the UIV of T2 with an all screw anchor configuration and a larger magnitude of kyphosis correction was associated with lower uproar rates or unplanned return to OR rates in this particular population. So that was kind of the gist of the main set of results, but we also tried to do a really good job of showing everybody what the most common configurations that we saw were with the different constructs and what the individual uproar rates were across those configurations.
So a question then about uproar. If someone initially has a proximal anchor setup that's all rib anchors, but then switches to spine anchors at the final fusion, would that count in this study as an uproar or a change in fixation? Or was that someone who maybe was tossed out because it was just the final fusion? So how did you control for that scenario?
There's two parts in that answer. The first one is that we only looked at spine-based anchors because there was, as you know, research in early onset, there's so many variables, so many confounders. So we wanted to compare apples to apples. So we did only this study with spine-based. So one of the inclusion criteria had to be primary dual rods, magic rods. So the second part of that question is, whenever we had an unplanned return to the OR due to implant-related complications, that was our main outcome. So not only unplanned return to the OR, but due to implant-related complications. So we define uproar as any change in the implants between the immediate post-op and the final follow-up X-ray that indicated surgical intervention, but it had to be due to implant-related complication.
Okay, right. And so, Bahar, you noted when you were talking about the summary that one of the factors that leads to uproar is kyphosis and the amount of kyphosis correction or the sagittal plane in general. And so for Behrooz and Fernando, would either of you change your anchor strategy based on the sagittal parameters?
Yeah, I think the fact that is not just the proximal anchors responsible for implant-related complications, and there are many other things, as you mentioned, etiology, severity of the curve, and flexibility of the curve, and also the size of the patient, the age of the patient. They're all factors that is involved. And I think the kyphosis is something that we all know that is kind of alarming factor. And I think if there was a rigid kyphosis, sometimes preoperatively they were placed in traction to have some correction. If it was a very flexible kyphosis and it was too much correction, that the patient would go back and start, more possibility of failure. Those were conditions. However, since this was not a randomized or it was a prospective study, the surgeons would do how they feel that is appropriate. My own experience, I always felt that if we do a proximal anchor, we have to make sure, start with 2 levels. Then if we really feel that there is a, additional factor for possibility of implant-related complications, then we add to it. So we can go to 3 levels and so on. It's better to do that rather than see the failures and then later have to extend. Sometimes people say, well, let's do LT3 and we have some room for extension. But if really, better stability, better fixation comes from T2, 2 level or versus 3 level, do whatever you think is the best based on the quality of bone, based on kyphosis, based on other things, etiology and so on. Congenitals may not be too much, they're more rigid than the others. Fernando, you want to add anything to it?
Well, I think we're also seeing information and also training bias, because I think this is where experts' opinions comes so valuable, because I was trained to do what Dr. A is saying. So I was trained to do 5 anchors at the top, and then even though we have, I think we have 3 configurations where we see 0% upwards. We could do all screws using those 6 anchor points. We could use screws and hooks, or we can stop at T2 and T3, and those end up being, in our study at least, at 0% upper, but then training bias and information bias. So there's been some fun discussion regarding the failure vector of each of the different anchors. So at least in my practice, what I do is I use hooks at the top, maybe stop at 2 or 3, and then again that nice discussion whether if you leave room for if you get a failure so that you could extend cephalad, but if you fuse too much, then you're not leaving some room for the spine to grow. But at least you have those 2 different vector failures, where if you have hooks at the top and screws at the bottom, they fail differently, and you follow those guidelines as to use 5 or more anchor points. So I think the expert's opinion, where information or where our data says 0% upper in these 3 configurations, this is where experts' opinions count a lot, in my opinion.
So, Fernando, you pointed out that there's, I think, at least 3, maybe 4 configurations that had 0% uproar. And none of those configurations were all hook-based. They were either screw-based or hybrids. But you were very careful, it seemed, in the manuscript discussion, not to advocate against a hook-based construct, and certainly, not to draw a line in the sand. And I think that, one, that's kind, because there are scenarios where we have to do all hook-based constructs, because of pedicle size or, other patient-based factors. But is there a scenario specifically in your practice where you would advocate for a hook-based fixation?
Yeah, I think there's definitely a role for a hook-based construct. Like you were saying, maybe you have dysplastic pedicles, those tiny pedicles in a nav, or congenital etiology where maybe you don't even have any pedicles available to put screws in. So definitely there's a role. But again, the fact that this is not a randomized trial and have that information bias, and there's surgeon preference, and it's a multi-center database, there wasn't availability for this data for us to look at in order to answer that question, if it makes any sense.
Absolutely. Behrooz, do you have anything to add to that?
No, I think that's true, and the location of hooks also makes a difference. I think there were cases where the hooks with the transverse process, and they're not as strong as supralaminar hooks. And I think having the option of having hooks for those cases that either the pedicle is very small, or at least having a opportunity to use, we know that the hooks and the screws are probably the same, maybe the same with the 3 levels. So yeah, I think it's good to have that training, with the hook placement, and not, be, forced to use the screws in very small pedicles. So I think as far as the factors that is influencing the results or the uproar, I think there were other factors that Bahar might want to comment on that too, that it was not considered or used in this study, but she was involved in another study that used the same data, and she may want to elaborate on that.
Yeah, I mean, I think one of the things that we tried to do, again, we're trying to constrain this particular paper with things that were well defined and that weren't super interrelated, although construct configuration by nature has to be interrelated. But a couple of things that we, a secondary analysis that we did, we used some machine learning techniques to try to get around some of the statistical limitations of the approach that we used in this paper, so that we could put a lot more variables into the analysis and really get a better understanding of the main drivers for uproar. And we included additional details like rod diameter and some more alignment features, and it allowed us to kind of understand the interplay between the patient size and etiology. And we included other things like ambulation status. Were they community ambulators? Were they wheelchair bound? We also included like the follow-up duration. So this particular study, we had a minimum of 2 years follow-up, but we kind of allowed it to be as long as we had data for, which in some ways could bias towards seeing higher uproar rates in older or patients that had a longer follow-up or had been in the system for longer. And so those are some factors that we were able to tease out in the secondary machine learning based analysis that, we did find things like rod diameter as being a driver for uproar. Other things like etiology. In our primary analysis in this paper, we saw that congenital patients had a higher uproar rates in when you just look at them by themselves, but then when you combined all the variables together, it kind of dropped out of the analysis. Ambulation status was another one that was a driver of uproar, and in fact, that was more like community ambulators actually had a higher rate of uproar than patients that were wheelchair bound. So some of those things were additional factors that we were able to look at on the back end with a different set of analytical tools, but that aren't included here, but also provide us some additional directions for future or interpretation or whatnot.
And you did that with much shorter time than looking at all the X-rays.
Excellent. And so if we can come to a conclusion and understanding based on the data that you've presented, that there is certainly a role for 3-column fixation on proximal anchors, and that having some amount of 3-column fixation is probably helpful to reduce uproar, do you think that kind of increases the value of enabling technologies going forward, where we would be able to place screws in these seemingly tiny, sometimes dysplastic pedicles, whether they're in-out-in screws or just kind of threading the needle on very small pedicles? And so one, I guess, question A is, do you see an increase in the value of these enabling technologies? And then how do you see that influencing our anchor choices going forward?
I think that personally, my experience with the new enabling technology, since I'm not doing surgery anymore, is not much. But I can just see tell you my opinion. Definitely, this is going to improve to the point, I'm sure, in the future that may be much more useful than what is now. However, my sort of advice to the younger generation is that shouldn't prevent you from, reading anatomy and knowing, looking at the CT scan, looking at, anatomy at the time of surgery, so you can, know, since, those data that is there, that's given, you are the only one that think when you do surgery. And that has to be always a factor. If you feel that is not right, it's not right. So knowing technology is great, but you shouldn't forget the basic understanding of anatomy of the patients, and being able to, if things goes off, you be able to do a freehand, implantation. So.
And I'll echo what Dr. A is saying, because I'm a little bit biased, because at least where I practice in the northern part of Mexico, we don't have these enabling technologies. So I was trained to do freehand. But even when we get this little kid that we're treating EOS, and we know we have to get right those T3, T4 screws. So even though we were trained at freehand, we want to at least fluoro those screws, because we want to get them right at the first time. So obviously, when you have a congenital or even a tiny pedicle, enabling technologies, I think they're a great tool, but they remain a tool, part of your armamentarium, if you will, because like Dr. A is saying, you're interpreting the information that these technologies are giving you, but you need to know the feel to know when you're right, when you're tapping, when you're putting down the screw. You need to know that you're in the right place, because that part cannot be replaced. Do you know what I'm trying to say? So yes, there's a role, but it doesn't replace anatomy training, freehand training, and that extra feel that you get when you're putting a right pedicle in the right place.
I think you're 100% spot on. I would describe these enabling technologies, which I am able to use pretty commonly here in Boston, as another piece of data. But without the other pieces of data, it's not helpful. You have to know everything else first and be assured of it before you can really accept the fidelity of that data.
Agree.
So then, last question. What is your preferred proximal construct on, standard 5-year-old idiopathic with a fairly flexible curve?
Well, I can tell you, what I did in my last case, 6 years ago. And at that time, I actually did 2 cases. One was with Greg Mundis together, and he put screws at the top, 4 screws, and then 4 screws at the bottom, and then we were all done. The case I did, used 2 superlamellar hooks at the top with 2 screws. I think it was 3 levels, but then so it was a combination of hooks and screws, and the screws at the bottom. So I think the other thing that I always feel that is important is we shouldn't just touch the elephant. When the construct fails, it probably has to do with the entire construct. For instance, a construct that the top is at T2 and the one is L4 or 5 with so many segments unfused behaves differently when there are only 8 level unfused between. So one of our fellows did a study that was a ratio of this levels that are hooked to the spine with the levels of free. And that also has something to do. So you have to look at the entire patient when we do decide on these implants techniques.
Yeah, I think in one hand is it's a tricky question because it's not a kitchen recipe where you see flexible curve, early onset, let's do this construct, right? You need to individualize each patient, but also I get another bias because I have the pleasure of working with a nonprofit here in Mexico, and whenever you're trying to teach something that is not something that is treated so commonly, especially in developing countries, you kind of have to standardize and make it easier to be more reproducible, safer. So whenever we try to teach this, or at least when we try to reproduce this, we try to aim, like Dr. A is saying, hooks at the top of the construct to have that kind of protection between different anchor failure vectors. So what I do is I do hooks at the top, TP hooks, and then back it up with 4 screws, T3 and T4, with the thought that I'm hoping that there's not going to be an unplanned return to the OR, and spanning more spine for it to grow and actually follow the plan of a growth-friendly approach.
Bahar, do you have anything else to add?
No, I mean, I think, part of the data that we've shown certainly supports the T2 3-level 6-screw kind of proximal construct approach, but and that was also the most common one. So I think that the commonality in looking at how many times we saw each construct tells us something about like the average population that is being that these constructs are being used on, and how, if you have somebody that is extremely rare, has a very complicated set of circumstances, that may be a very unique set of circumstances versus, somebody that you can apply this common construct to, that's someplace where we can use these data to help support what it is that we're trying to do. So I'm not a surgeon, so I can't inform on what the preferred construct would be in the OR, but if the data were to tell us what it is that we like to do based on the most common constructs and the ones that are the most successful, the T2 3-level 6-screw proximal construct would be my interpretation of that, of the answer to that question.
All right, so I want to thank all 3 of you for this paper, this great manuscript. Thank you for coming and being on the podcast today. Once again, everyone, this is Dr. Bahar Shahidi, Dr. Behrooz Akbarnia, and Dr. Fernando Rios. I would like to remind everyone listening or watching that annual meeting abstracts are open. And so clean up your data, get your abstracts in. We want to hear the best projects. IMAST registration opens December 3rd. The IMAST meeting this year, or next year now, is going to be in Glasgow, Scotland, and our annual meeting will be in Charlotte, North Carolina. So thanks so much, everybody, for being here, and I hope you have a great day.
Thank you, Grant, and thank you, podcast committee.
Thank you for having us.
Thank you.